Hello and welcome to the Ethical Ground Rounds for Section 103. In our case scenario, we're going to be discussing a patient that had a DNR, or Do Not Resuscitate order, and a power of attorney. This patient was being treated at the hospital for pneumonia and was scheduled to be discharged the following day with comfort orders for end-of-life care to be conducted at home. Unfortunately, some of the patient's family members did not agree with the patient's decision to quote-unquote give up, and they wanted her to continue to stay in the hospital and to receive medical treatment. So while the patient's power of attorney was away, these family members got together and decided that a good idea for them to do would be to call the company that delivers the equipment, the oxygen, hospital beds, bedside commodes, things of that nature, and to cancel the order for delivery of those essential tools to the home. Once this decision had been made by the family members, the patient could no longer go home as scheduled because, of course, if the equipment was there, if the equipment was not in place, then there was inadequate tools there for care to be provided. So it became necessary for the patient to spend the remainder of the weekend in the hospital, since the delivery had been scheduled on a Thursday and could not be rescheduled until the following Monday. That necessitated the patient remaining over the weekend. Unfortunately, during the weekend, the patient's condition deteriorated, and the family insisted that medical intervention outside the predetermined plan of care be administered in the form of CPR and other extraordinary measures to maintain her survival. After this had happened, after the DNR had been violated, so to speak, a time after that, the patient's, I believe it was son, but at any rate definitely power of attorney, arrived and was very initially upset that that had happened and questioned the family as to why the other family members did not honor her wishes and his instruction. And obviously there was some heated conversation that was put to rest by the family members. It was pretty well stifled when the family members explained that had the mother been at home, as she had been scheduled to have been at home, she would not have received the emergency medical treatment that was given to her, and more than likely she would have died. To which the power of attorney, sadly responded that it was a good thing that she had stayed then. So, kind of a sad statement about the family's unwillingness to abide by the wishes of the patient, and also maybe a lack of understanding on the power of attorney's part about exactly what the plan was. If his statement was to say, well, it was a good thing that she stayed, when everyone was pretty much under the understanding that was the intention, that it was time for her to go home so that she could die at home as she had desired. So this case scenario brings up probably a number of questions, but three that we'll like to highlight here. The first is, what is a DNR, or a Do Not Resuscitate order? The second, what is a power of attorney, or a durable medical power of attorney? And just exactly what is end-of-life care? And certainly the last one is going to be the trickiest of them to answer, but we'll try and give those a shot. So in looking at a DNR, or a Do Not Resuscitate order, essentially it's an order written by a physician and placed into the patient's medical record, instructing other healthcare providers that CPR and other extraordinary measures to sustain life should not be conducted. This can happen for one of two reasons. The one that happens least often is a determination is made by the physician that that heroic measures are futile. So a good case scenario for that would be a physician might put in a Do Not Resuscitate order if the patient had brain damage. There are some situations in which the physician will make this decision on their own. This does not happen as often, I think probably more than likely for liability reasons than anything else. More often than not, though, a DNR is placed in the patient's medical records at the behest of the family, the power of attorney, or most often the patient themselves. And so we learned about the respect for autonomy in our leadership class, and the physician has a moral obligation under this concept to abide by the choices of the patient. So if it's the patient's desire that no extraordinary measures be taken, as long as that they're capable of making that decision, or someone is capable of making that decision on their behalf, then that is something that the medical profession requires us to comply with. And so in this next clip, or next slide rather, we'll look at a short video clip and see if these folks here can explain it a little better than me.
The DNR, or Do Not Resuscitate, is perhaps the best known advance directive. The DNR is very The DNR, or Do Not Resuscitate, is perhaps the best known advance directive. The DNR is very specific. A DNR says this and only this. If you are found without a pulse and respiration, medical staff won't try to restart your heart or breathing with either chest compressions, shocks, other machines or tubes, or medications. It's important that you know an order for DNR is a choice. It is not mandatory. It's a choice that you should make when you are in a condition to do so. If you are in a hospital, nursing home, or assisted living, a DNR is an agreement between you and the facility. If your heart stops beating or you stop breathing, it is your choice that nothing be done to resuscitate you. If you do not have a DNR in place, your agent that you named in your healthcare proxy will make the decision about resuscitation.
For example, if I was hit with a car and on the way home and I was in an accident, I would want my son, who's my healthcare proxy, to be able to talk with the doctor, know what my wishes are, give me every chance for a reasonable amount of time. And at that point, he has the decision-making power, because I can't speak for myself, to do what he thinks what I would want. Not what he would want, but what I would want.
As healthcare professionals, it's important that we know what your medical wishes are, especially in an emergency situation, so that we know what kind of treatment you would want, what kind of treatment you wouldn't want, so that we're providing you with the best care possible according to what your wishes are.
And know that at any time, you may change your mind. You can cancel a DNR order whenever you want. Remember, it is entirely up to you.
In the next section, we'll talk briefly about exactly what it is to have a durable medical power of attorney. So the durable power of attorney for healthcare is a limited power of attorney, so a legal document that allows others to make decisions for you. So it's a limited durable power of attorney created for the purpose of making healthcare decisions only. It doesn't give that person any right to your property or to your estate, or name them executor, or give them any other additional abilities or responsibilities other than to make healthcare decisions for you. The durable power of attorney for healthcare can do everything that a living will can do, and in addition to that, it gives your agent the power to actively remind your physician of your wishes. Should they forget or be influenced by family members, that person can speak on your behalf when you are unable to. So in essence, when you're incapacitated, your power of attorney will make all of your healthcare decisions for you, and hopefully follow your wishes as you've outlined them to that person. So any decision must also, of course, be in the range of accepted medical practice. So, if you have a power of attorney who's requesting that something, untoward or unprofessional or not necessarily prescribed through the normal course of care, obviously the physicians and other people can overrule that, and there are ethics boards and other avenues to be pursued should the power of attorney and the physicians disagree about what's in your best interest or what your wishes actually were. excuse me, I have some instructional video for power of attorney as well on the next slide. It's a little bit dry, but we'll listen to some of that and see if the attorney can explain it just a little bit better than I have. So.
Attorneys where medical is totally different. So, medical power of attorney is a legal document that transfers medical decisions from one person to another. And that other person is sometimes called a medical representative, healthcare representative. I mean, depending on where you are in the country, it's called all different things. But it only comes into effect when the principal is not able to make the decisions for themselves, which means that, say, someone goes out in their car and unfortunately gets into a car accident and is not able to make medical, which the examples are below, medical facility decisions. For example, when and if should they go to a rehab or should they go to a mental institution. And also, if you're in the case of medical treatment decisions, that can mean anything. I mean, doctors usually give you a couple of options if it's that serious. And also one of the options is the decision to not use medical treatment on the person. So, which is why you want to really trust the person that you leave in charge because they have a lot of power. I mean, they have the power over your life. And here are a couple of other side questions that we usually get in reference to medical power of attorney. And do I have to pay my medical representative? And that is no. Most of the time, people that you're going to select to be your representative is going to be family. So you're not going to need to pay them. But in most states anyway, it's illegal to compensate the representative for anything more than just their typical expenses. They are allowed to get gas, food, if they had to come in from out of town, hotel stay. They are allowed to get paid for that. But other than that, they are not able to get any other compensation. And the next question is, do I have to file the medical power of attorney form with your state? And this is a big question, and the answer right here is no. You just want to make sure that you keep it in a safe place. A lot of times people will sign these things, but will forget where they put them, and the person will be in the hospital, and time is always of the essence in those situations. And you just want to make sure that the power of attorney form that you sign is in a easily readable place to get. So it wouldn't hurt to also give one to you, an actual copy to your attorney, as we've stated in this blog post. And of course, where can I get a medical power of attorney form? Well, we also run a website which is called powerofattorneyform.com, and as you can see here, we have this is our blog, powerofattorneyform.tumblr.com.
So from there on out, that pretty much turns into a commercial, but we'll skip the rest of that video. And that leads us to our third question: what is end-of-life care? And end-of-life care, I think, is probably a very diverse topic, but at its essence, it's a choice, and it's a choice that's made by the patient to accept only that care, that palliative care, that care that it improves the remaining quality of their life for the time that they have left. And it's a decision to try not to cure or put their disease into a remission, or to stop the dying or the disease process. It really is simply a decision to be comfortable during your last days, and to die in a manner of your choosing with as much dignity as you possibly can.
Here's to your health.
Here's to yours.
At age 69, Cora Kriechbaum made a courageous decision.
I wanted quality of life rather than quantity.
She had already survived 2 recurrences of breast cancer. Then the disease returned and spread to other organs. Her doctors were not hopeful. So this time, Cora said no to chemotherapy and opted instead to die at home.
If I have a little time left, I really wanted to spend that time with my family. And so it's not so much remission that I was looking for. It was more, let me get back to normal. I want to be able to eat and drink. Okay. So that was my mission. No more remission, but the ability to have some fun and enjoy what I have left.
Cora had already spent decades in hospitals, not as a patient, but as a nurse. That influenced her decision to say no to more chemotherapy. Instead, she chose simple comfort care, the kind doctors often opt for.
Physicians, I won't say invariably, but almost always choose for deaths that maximize opportunity for dignity, making sure that they are dying with their families, at home, with no pain.
Dr. Ken Murray is a retired family physician. He attracted unexpected national attention when he wrote an article published in Zocalo in the Wall Street Journal called How Doctors Die. And how do they die? Well, less often in hospitals with feeding tubes and last resort medications, and more often at home with little medical intervention. But why? What do doctors know that we don't? Well, take, for example, cardiopulmonary resuscitation, CPR.
He's in fifth.
CPR is a staple of medical TV shows and movies. This is how it's depicted.
Clear.
And on TV, it works.
But the reality is drastically different. A recent study in Japan looked at nearly 100,000 cases of CPR performed outside of hospitals. Only 8% of those resuscitated survived a month, and only 3% of the patients resumed a normal life.
When you look at what physicians choose at end of life, would you want CPR? More than 90% of physicians say no. But if you ask the public at large, only 25% say no.
Hi, Cora.
And when asked where people want to die, the vast majority of Americans say at home.
This will help a lot.
But in practice, most Americans die in hospitals. One reason may be lack of information about hospice.
I think it's a misunderstanding of what hospice is or palliative care is. I think most people believe that you're giving up instead of helping somebody transition or die with dignity. Here you can see the aortic valve, and there's some blockage of the valve.
Dr. Dan Eisenberg is the medical director of cardiology at Providence St. Joseph Hospital in Burbank. He deals with end-of-life issues all the time.
With machines helping, with antibiotics, with feeding tubes, with shocking people, with pacemakers, you can keep life going. But is that what you really want? I think we overuse end-of-life care with technology way too much.
And Cora had seen plenty of that technology firsthand.
Cora, being a nurse, had, I suppose you might say, seen enough death or enough misery or enough suffering that she didn't want to go through that herself. She understood both sides of the issue. There's no doubt about that.
My parents had already had do not resuscitate forms in their living will. So, and we had talked about it as a family, and I think my mom being a nurse, she had seen things that, you know, we were not really aware of. With them being so open about having DNRs and being so open about their life decisions, it prompts everyone to take a closer look at what you're doing in your own life.
I don't think it's necessary.
Right.
That's another thing doctors do differently. A 2008 Johns Hopkins study found that 65% of physicians spell out their end-of-life care instructions in writing, compared to only 20% of the general public.
I think it's probably a good idea to have a discussion with your family about the taboo subject of death. I've talked to my wife about death, and recently even, and she said, tears came to her eyes, and she said, don't talk to me about death.
What would you have told your wife if she were willing to hear it?
I would probably tell my wife that the decision for me to live in a situation where I could not speak for myself or give any kind of communication about what my wishes would be at that moment should be based on the probability that I can come back to being me again.
Dr. Murray also faults physicians for not being more honest with their patients.
This is one area in which I think doctors are terrible in communicating risk and benefit.
How do you want to die?
Well, there's no question that I go with the majority of my brothers and sisters. Dignity, being surrounded by loved ones, lack of pain, those are absolutely the way that I would want to go.
I'm resigned to the fact that my life is coming to an end. I'm resigned to the fact that my body is giving out. I think you come to that individually, that decision.
Cora died in June, at home, surrounded by her family.
I would never have called 911. I had to let her pass. I would not want her to live an hour longer with the pain that she was in. I miss her, but I wouldn't have her back with that pain. Period. I just wouldn't.
So, kind of some heavy stuff there, and as we kind of look at that video and move forward and actually look back at our own scenario, it brings to mind a few ethical issues that we'd like to discuss about our case scenario and how our situation was handled. So the first ethical issue that we kind of looked at was the fact that this patient had a do not resuscitate order and was scheduled to be discharged to home for their end-of-life care. And so this means that the patient didn't want the CPR, didn't want the extraordinary measures taken to prolong her life. She had already come to that difficult decision. Additionally, she was being discharged home with comfort orders. That's where she wanted to be. She didn't want to be in the hospital anymore. She was wanting to be home, surrounded by family, and she just wanted to be at home and die with some dignity and not be in pain, much like it was mentioned in the video. So the conundrum comes into play, and where you have that little bit of imbalance is when you get our well-intentioned family members who choose, out of probably the best of intentions, to simply ignore this choice. And in this particular case, our case, really went as far as to sabotage the patient's efforts to get home by calling that delivery service and canceling the necessary tools and accoutrements that they would need to facilitate the care that she had planned for. And so basically what happened is the family wanted to make these choices for the patient, and didn't want to allow the patient to make their own choice, or didn't feel as though that patient knew what the right choice was, and so took that choice from her. And then, interestingly to me, I found it interesting that they did not do this until after the patient's only real defense, their power of attorney, was unavailable. So it was definitely a kind of a well thought out plan, and probably a plan with good intention, but with some sad, in my opinion, outcomes. And so the second ethical issue that we kind of looked at is that neither the patient or the hospital or the power of attorney or really anybody was consulted by the equipment agency before they agreed to cancel this. So the order for the equipment was placed by by a nurse, by the case manager for that patient, an employee of the hospital, and for whatever reason was able to be canceled by someone other than that person or the patient themselves. And obviously, these people probably get a lot of calls for canceling this type of equipment. I imagine when someone passes away, the equipment company wants to make it as simple as possible to not bring the equipment out and have to come back and get it. So we can totally understand and sympathize with the notion that this would happen, but it seemed unclear to me as to whether or not the vendor had any kind of legal obligation to the patient or the hospital, or possibly even to the power of attorney, to identify the callers and make sure they had valid authority for not bringing this equipment out, which of course led to the patient's, in my opinion, sabotage of the patient's care. So at least a lack of due diligence, in my opinion, was done here. And once again, it's probably a gray area, but certainly an ethical issue that we felt should be considered. The third issue that we had on deck here was that during the weekend, and this is probably the most obvious, during the weekend the patient's condition deteriorated and the family insisted that medical intervention take place, which was obviously outside of the patient's wishes and the patient's predetermined plan. And of course, as is often the case, when there is a conflict and the patient's unable to speak for themselves, I think a lot of times, these predetermined instructions are ignored for the quote-unquote good of the patient. And certainly we agree if the family, if the patient's unable to speak for themselves and the family demands medical attention, whether or not is what the patient wanted, obviously the nurse or the doctor should be, proactive and should follow the demands of the family. You're never entirely sure what the patient's last or most recent request was, and the patient very well may have changed their mind and shared that with the people there, and obviously there's a certain amount of liability by failing to act. So the ethical issue in question isn't an issue taken with the healthcare providers as much as it is the family themselves, who once again, were trying to do their best with what information they had or what they believed to be right. It's obviously a very hard thing to say goodbye to anybody if there's someone that you love, especially if you're looking at that person and they're making a choice that you disagree with. However, there must be some credence lent to the idea that the ability to respect that choice of that person that you're losing, the person that you love, is one of the quintessential elements of humanity, and really should be respected if that person is to be respected, and ultimately if their memory is to be respected. And issue number 4 here is as it relates to the power of attorney themselves. This is this was bizarre to me in that the power of attorney, when he came back, was angry and questioned the actions of the family, and demanded an explanation from them, and wanted to know why things had not gone as planned. And so the idea the patient would go home to die was kind of a predetermined decision. However, once the family explained to the power of attorney that had they not been there, had the patient not been there, had they not taken the actions that they had taken, the patient would have died. And once that was explained to the power of attorney, he was just as much in cahoots as the rest of them by saying, well, it's a good thing that she was here, in fact validating the choices that they had made. And so there may be some issue there with whether or not that person is the right person to be the power of attorney, or whether they fully understand the concept that this person had. The idea was for this person to die, and to die soon. So it's sad that the family believed that their actions resulted in a positive outcome. Even though it did extend the patient's life, it didn't necessarily extend that quality of that life. And I think it's sadder still that the one person whom that patient trusted to speak on her behalf also failed to have the strength of character to speak up against the family's wishes and to ensure that those wishes be honored despite what his current point of view was. So that is our presentation, and you see here a list of the references that we used to help us, collect these opinions, and some of the URLs for the videos that we collected. I want to thank you all for your attention and for watching this presentation, and of course we'll now take any questions. Thank you.